Elimination of cervical cancer from the globe, which is launched by the President of or Director General and the whole office of World Health Organization. They committed to eliminate a single cancer from the world, that is cervical cancer, within 100 years. So in this context, we are going to arrange this scientific conference or the seminar. Cervical cancer is incurable. It's very surprising to hear this statement, but this statement was given by the father of medicine, the Hippocrates. So now we are telling that cervical cancer is curable, but the World Health Organization, they are Bangladesh Cancer Society, and of course, this session will inaugurate by our living legend, our philosopher, and the guide of the oncology, Professor M.A. Hyde. We have 4 speakers here to enlighten us from their wisdom, knowledge, and experience. We have 3 experienced panelists in our session. They will give their the comments on the presentation of our presenters, and definitely we will have question answer session at the end of our all presentations and comments from the panelists. So I on to the panelists. We don't want to waste our time. First of all, I would like to request for Dr. Sadia Samin to start her presentation. And I would like to request every speaker to speak or to present their cases and to finish their cases within 7 minutes. So we will be on time. So Dr. Sadia Samin, please.
Okay. Thank you, sir. Thank you, sir, for inviting me in this panel. Sir, this is the month of cervical cancer awareness month, and we should recommend the things or obstacles in this regard to manage the cervical cancer. And I want to share my screen now. Sir, is
দেখতে পাচ্ছি
but
দেখা যাচ্ছে স্যার?
দেখা যাচ্ছে but ঠিকই
ma'am please click enable editing here.
Okay.
Yeah, just middle এখানে একটু বড় করে নেন তাহলে হবে। জি, আর নিচে আপনি প্রেজেন্টেশন মোডটা এনেবল করে রাখুন তাহলে হবে ফুল স্ক্রিন করে। জি, থ্যাংক ইউ।
Now is this okay?
হ্যাঁ।
Yes, sir. So, a cervical cancer-free future, first ever global commitment to eliminate a cancer. I want to present the epidemiology of cervical cancer today. I am Dr. Sadia Sharmin, Associate Professor, Department of Clinical Oncology, Bangabandhu Sheikh countries. This is the Globocan report. 5,69,847 cases diagnosed, and death rate is also high. Most commonly diagnosed cancer in 28 countries and leading cause of cancer death in 42 countries. I already told that cervical cancer ranks second in the Globocan report, and its mortality behind the breast cancer in lower age settings. In Bangladesh, institutional based. What is the scenario of our department? Last year, 135 cervical cancer patients attended in our clinical oncology department. And last year, we started our radiotherapy facilities from August 2020. And till now, 18 patients are already treated with cervical cancer with radiotherapy in this pandemic situation. Average age of diagnosis, 35 to 55 years. Median age is 48 years, and 0.2% are diagnosed under the age of 20. The common histologies are squamous cell carcinoma, and there are some rarer histologies here also. Now, what are the causes of carcinoma cervix? Human papilloma virus are associated with carcinoma cervix in 99.7% of cases. Others. There are 100 types, but for cervical cancer, there are some high risk types of human papilloma virus. These are 16, 18, and 45, 31, and others. HPV 16 and 18 causes 70% of cervical cancer. 80% of HPV infection are transient, and it is the main point to where we can work on, so that the screening is very carcinoma in situ neoplasia after the HPV infection, and 1% develop invasive cancer. If we screen our female patients in this regard, we can diagnose our female patients in the pre-invasive stage. Important, this is the HPV vaccination, health education, and secondary prevention, the cervical cancer screening and treatment of precancerous lesion, I already told, and the tertiary prevention is the early diagnosis and proper treatment. Now, the most important part is HPV vaccination. I already told that the HPV infection is the one of the most important cause of development of carcinoma cervix. WHO recommends 2 doses of vaccine 6 months apart between 9 to 13 years of old, and 70% protection against carcinoma cervix can be given by the EPI program, but it is currently the HPV vaccination is not included in national vaccination program of government of Bangladesh. And in Bangladesh, there are 2 available vaccines, that is the Cervarix and Gardasil, but right now these 2 are not available. The screening populations are, the target population is 22 million, and done by VIA, that is the visual inspection with acetic acid, and VIA positive cases are evaluated by colposcopy. That is the way we can screen our target population. What is the Bangladesh situation? Bangladesh, like other developing countries, faces a burden of cervical cancer. And I have already told that there is 8,600 new cervical cases are diagnosed due to lack of screening and a high prevalence of risk factor, that is the early marriage, early initiation of sexual activity, multiparity. It is the second leading cause of cancer death among our women. In BSMMU, there are cervical and breast cancer screening program and training center program are ongoing, and the target groups are 30 to 60 years. The number is 22 million, and there are total VIA centers are 417. That is 10% we can coverage. And the performance of VIA in Bangladesh, that is the chart where we can see in 2019 from January to December, these incidence remains underestimated. Opportunity is screening, and it is already the policies make. The paper-based record are maintained, and electronic data tracking with population-based also initiated, and it is on process. What is the WHO program, WHO strategies? It is the 2020 to 2030 accelerated plan towards elimination. The vision is a world without cervical cancer, and goal is below 4 cases of cervical cancer per 1 lakh women years. And 2030 targets are 90% girls will be fully vaccinated with HPV vaccine by 15 years of age, and 70% of women should be screened, and 90% of women identified with cervical disease receive treatment for precancer lesion or invasive cancer. Is it possible of Bangladesh? In Bangladesh, it is the big question, and we should try to achieve our goal. College hospitals and all district hospital and mother and child care welfare centers and selected Upazila health complexes are ongoing VIA test, and there are already 17 VIA centers in 64 districts in Bangladesh, and 23 colposcopy clinic in mother and child care welfare centers and BSMU. Already showed that is the performance of VIA in Bangladesh. And in colposcopy clinic of BSMU, there is 51% of VIA positive cases diagnosed as precancerous or cancerous condition and treated accordingly. These are some papers or research works
Dr.
done.
Sadia,
Yes, sir.
you have 1 minute, please.
Yes, sir. Already done in our BSMMU Gynae Oncology department to see that is the what types of HPV, that is the role of molecular biomarker in HPV infection oncoprotein in cervical cancer screening. And the conclusion is HPV E16 oncoprotein test is highly specific and is an effective triage test to reduce colposcopy referral for the larger number of false positive test outcome seen with VIA. This is another research work. And these are the obstacles introducing HPV test in Bangladesh. There are at the management challenges. And we should try to introduce HPV test in Bangladesh. And by this, we can, in near future, a simple, affordable, and accurate HPV test need to be evaluated. This is the way we can reduce the risk. And my recommendation is introduction and implementation of nationwide vaccination program for elimination of cervical cancer and strengthening of screening tests. Thank you. Thank you, sir.
Thank you, Dr. Sadia, for your presentation. Now, that is the issue. What is the situation in our country? We want to show this by the presentation from Dr. Sadia Sharmin. Definitely now, I would like to request Professor M.A. Hai, because we have seen the scenario of our country and the strategy of World Health Organization is 90-70-90. In this context, not only just to inaugurate the session, you how we can proceed to achieve our goal, which is launched by World Health Organization. So in the name of inauguration, we want to have the words from your wisdom, Professor M.A. Hai. Please, sir.
Bismillahirrahmanirrahim. My dear colleagues, participants, members of the BSRO and BCS, Assalamu alaikum. I'm happy that both the two organizations jointly organized this seminar and kindly invited me here to speak and given chance to speak. Cancer of the uterus is one of the greatest threats to the women's health worldwide. We have seen from the Sadia's lecture. WHO has declared war against cervical cancer for eliminating this evil from the world. This is for the first time WHO is trying to eliminate a cancer. Before that, we have eliminated quite infectious diseases like polio, smallpox, and other things. We must join wholeheartedly with WHO in this war. At this stage, I remember the famous speech of our great leader, father of the nation, Sheikh Mujibur Rahman, right to our leader, where he said, fight with the enemy with whatever weapon you have in your possession, we shall liberate our country, inshallah. This very speech created immense strong determination in the minds of the people, fight and successfully win the liberation. We shall have to fight with such a strong determination against cancer cervix to get rid of this evil. HPV infection is considered to be responsible for about 70% of cancer cervix cases. According to an estimate, almost 80% of women can be infected at some point in their lifetime. Most of the infection clears naturally. WHO recommends life course approach to cervical cancer prevention control in 3 steps: primary prevention, secondary prevention, and tertiary. I will try to say something about primary. WHO recommends for primary prevention. Number 1 recommendation is HPV vaccination for girls aged 9 to 14. And number 2 is for girls and boys as health information and warning against tobacco use. Sexuality education tailored to age and culture. Condom promotion, provision of these engaged in sexual activity. For those who are engaged in sexual activities. And male certificate. HPV vaccination, Sadhya has told nicely, but we have to depend on certain factors. The dependency, availability, finance, and again application towards. So we have the mechanism to vaccinate, or because we have successfully vaccinated many previously, but we shall have to organize this. I shall have to make available HPV vaccines. Or something like this. But what we have in our hand will requires a position in our possession. I like to emphasize that most of the people in Bangladesh this is in this, this I am uttering because all the religions teach us to maintain cleanliness and purity of our body and mind. Mind it. Cleanliness and purity of our body and mind. If we can maintain cleanliness and purity of our body and mind, almost all the diseases, including cancer to some extent. Most of you might be knowing that about 1 in 100,000 advanced cancer patients gets cured without any treatment period. You will find it in the spontaneous regression of cancer and global chart. That means our body has inherent power to heal cancer as well, other diseases. We still do not know exactly clearly the mechanism how body heals itself. Scientists are trying hard to find out the phenomenon. Let us now see what the creator of our body recommended about healthcare that may be related to prevention of cervical cancer. Knows everything about our body. She has created us. We must give importance. The Holy Quran in chapter 24, verse 30 and 31 repeats, tell the believing men to lower their eyes and guard their private parts. That is purer for them. Surely God is aware of whatsoever they do. And 31. And tell the believing women to lower their eyes and to guard their private parts and to accept that which is visible thereof. And let them draw their kerchiefs over their breasts and not display their adornment except to their husband, their father, and their relative. There are also several verses directed us to take good care of sex organs and also try to remain aloof from extramarital sex. If we can follow these instructions, I believe cancer cervix will be prevented to a great extent. Sorry. Use of condom married couple is a good suggestion. Male circumcision is mandatory for Muslims. It seems that the incidence of cancer cervix is probably published annual report of NICRH reveals that frequency of cancer cervix is 7.7% of all cancers and 16.7% of female malignancies. As far as I remember, female malignancies in 70. This decline of cancer cervix is possibly due to the use of condom and screening by higher methods. Hope that we shall be able to eliminate cancer cervix easily if we can follow these things. So thank you very much for patient hearing, and I wish you good luck and
Thank you, sir. Thank you, sir, for your advice, and particularly the personal, the advice to prevent cervical cancer. When the women are coming to us by avoiding the safety net of these different preventive measures in the globe, and particularly in our country. So cases are coming to arises how we will proceed to treat our patient. So this is the time to speak, to have the speech from Professor Dr. Jannatul Firdaus. She is a head gynae oncology of Bangladesh Bangabandhu Sheikh Mujib Medical University. So I would like to request Madam to start her deliberation. Professor Jannatul Firdaus.
Thank you, sir. Sir,
Yes.
Can you see my slides?
Yes.
Okay. Sir, there is a small correction. I am a professor of Department of Gynecological Oncology, and our at this moment our chairman is Professor Ashraf-un-Nisa.
Okay.
Okay.
Thank you very much.
Respected chairpersons of today's webinar, respected teachers and learned audience, Assalamu alaikum and a very good evening. It is my proud privilege to present in this prestigious webinar, and I'm grateful to the organizers, especially to Professor Ghulam Muhyiddin Farooq sir, for inviting me as a speaker. So, greeting from Department of Gynecological Oncology, BSMMU. For next couple of minutes, I'm going to talk about role of surgery in cervical cancer, types of surgery in cervical cancer, advantage of surgical treatment, stage-wise surgical treatment, indication of surgery, lymph node, and prognosis of surgical treatment, surgery for relapse. So, cervical cancer, we all know that cervical cancer is clinically staged and it is done by thorough pelvic examination, rectovaginal examination, occasional examination under anesthesia. In 2018, Gynecologic Oncology Committee of FIGO has incorporated the imaging and pathological findings to assign the stage. Surgery in cervical cancer is limited to patients with early stage cervical cancer, that is stage 1 to early stage 2A1. Some European and Asian centers treat patients with stage 2B disease. The goal of surgery is to remove the tumor and the potential sites of metastasis. Occasionally, adjuvant radiation therapy and/or chemotherapy. The type of surgery depends on several factors like stage of cancer, fertility status, age and general health of patient. What are the advantages of surgery? Tissue for histopathology and accurate extent of disease can be determined by surgery. Primary disease and potential site of metastasis is removed. Surgical exploration, staging, and adjuvant therapy can be accurately targeted and easy to manage. Ovarian function can be preserved, and it is possible to retain more functional The types of radical hysterectomy, Pivar et al. Type 1 to type 5, and Carlo and Moro described 4 types of radical hysterectomy according to the extent of resection, type A, B, C, D. And type A correspond to the type 1s, that is extrafacial hysterectomy. Type B correspond to the type 2 or modified radical hysterectomy. Type C correspond to the type 3 hysterectomy, and type D correspond to the type 4 PIVAR classification of radical hysterectomy. This is but we commonly perform up to type 3 radical hysterectomy or type C radical hysterectomy. This is a figure of radical hysterectomy showing the extent of the surgery. Less radical is class 1, that is simple extrafacial hysterectomy, and more radical type 2 or class 2. And usually we perform either type 2 or type 3 radical hysterectomy. And in addition to radical hysterectomy in cervical cancer, we perform pelvic lymphadenectomy, because pelvic lymphadenectomy has a certain therapeutic role and cervical cancer. Now, stage-wise surgery. Early stage, that is stage 1A1, without LVSI, there is chance of lymph node in metastasis very low. So simple extrafacial hysterectomy is enough for this group of patient. But if fertility is an issue, then cervical for stage 1A1 with LVSI and stage 1 of lymph node involvement in 7.5% of cases, modified radical hysterectomy and bilateral pelvic lymphadenectomy is the choice of surgery. And when fertility preservation is an issue, radical trachelectomy with bilateral pelvic lymphadenectomy is recommended. For stage 1, B1, B2, and 2A1, actually this group of patients are ideal candidates. Surgery, we performed a radical hysterectomy or type 3 hysterectomy with bilateral pelvic lymphadenectomy. And here also, if fertility is an issue, then we can do radical trachelectomy with bilateral pelvic lymph node dissection. Now, recent update is tailored surgery. In patient with small stage 1B1 cervical cancer, parametrectomy can size of the tumor is less than 2 centimeter and LVSI is negative, because chance of parametrial invasion in this group of patient is very low, only 1.2%. For stage 1 B3 and 2 A2 tumor, though these are operable stage, but this bulky group of patients, usually primary surgery is discouraged as risk of involvement of the retroperitoneal lymph nodes, deep stromal involvement, and need of adjuvant radiotherapy that increases morbidity and compromises quality of life. So concurrent chemoradiation therapy is the standard of care for this group of patient. But in selected patient, in this bulky group of patient, we can do surgery if the patient is young, medically fit, adenocarcinoma variety, and no lymphadenopathy on pre-op imaging. Now, surgery for the advanced stage disease, is there any role? Yes. In advanced stage, also there the disease is localized, but there is adnexal pathology or tumor size more than 2 centimeter, then before giving radiotherapy, we have to remove the adnexa and enlarge lymph node. For stage 4 disease, in case of in patient with VVF or RVF, and if the patient of systemic disease, then there is also a role of primary pelvic exenteration, though rarely we perform. Now, there are certain complications of radical hysterectomy. Intraoperative complications include hemorrhage and injuries to the surrounding structure. Early postoperative complications are fever, urinary tract infection, thromboembolism, genitourinary fistula, pelvic abscess infection, cardiopulmonary depression, atelectasis. And late complications are bladder, bowel, sexual dysfunction, lymphedema, and lymphocyst. Now, nerve sparing radical hysterectomy. Currently, this hysterectomy is emerging. Avoid bowel, bladder, and sexual dysfunction, the hypogastric nerve and the pelvic splanchnic nerve, that is the autonomic nerve to the pelvic structure are dissected out and preserved from uterosacral and parametrium. Now, disadvantages of surgery are immediate morbidity is more, and it cannot be done in all stages. Expertise is required, and in some cases, patient may not fit for surgery. Now, there are certain conditions where surgery is indicated. We know that equal rate may be obtained with primary radiation therapy in early stage of cervical cancer, but certain group of patients, these are the surgery is absolutely indicated. Like in younger women, we know that the ovarian function should be conserved. When cervical cancer is associated with any pelvic pathology like myoma, PID, ovarian tumor, cervical cancer associated with pregnancy, vaginal stenosis is there, and certain cases of recurrences. Radical trachelectomy is a part of fertility-sparing surgery. 30% women diagnosed with cervical cancer are less than 40 years, and 40% of them have early stage disease. So, for fertility-sparing surgery, is an option for them, and radical trachelectomy is the usual procedure where cervix, upper part of the vagina, parametrium is removed while maintaining fundus and adnexa. Diagnosis of a patient when the tumor size is less than 2 centimeter, stage 1A1 to 1B1, and no neuroendocrine or small cell cancer. And this type of operation has good surgical outcome, oncologic safety, and obstetric outcome as well. And another update is sentinel lymph node identification. Sentinel lymph node is the first lymph node to which cancer cells are likely to spread from a primary tumor. And by using this sentinel lymph node identification, we can avoid complications of thorough lymphadenectomy, but it is still investigational in case of cervical cancer. Now, prognosis of cervical cancer, 5-year survival rate for early cervical cancer is very good, more than 85%. Now, surgery for the relapse cases. Surgery for the relapse, if the relapse is central disease and patient has history of prior radiotherapy, then there is a role of exenteration, even radical hysterectomy if the tumor size is very large. So recommendations are in case of early cervical cancer, a recent development in imaging has changed the paradigm shift in the management of cervical cancer, and use of any of the imaging modalities according to the available resources in addition to clinical assessment should be used. We should use imaging modalities. Surgical management should be based on the disease. There are a number of surgical options for the treatment of women with early cervical cancer, but the feasibility of oncologic outcome of this technique are priority. And the decision to use newer techniques depends on the surgeon's competency. Thank you all for patience. Thank you.
Thank you very much. Thank you, Professor Jannatul Firdaus, for your nice presentation, and of course, every corner of surgical approach in management of cervical cancer. As we know that at least 90% cases should be finally that should be treated to eliminate cervical cancer from the globe. And you have put 4 very special recommendation. Definitely our policymakers will go through this recommendation when we will send this to World Health Organization from our this session. So as we know, radiotherapy has a very big role in management of cervical cancer. So I would like to request our next speaker, Dr. Ronak Jahan Amin. She is Associate Professor of Radiation Oncology in National Institute of Cancer Research. Professor Amin, please start your presentation. You have 7 minutes to present. Thank you very much.
Thank you, sir, for giving me the opportunity to present my topic, respected chairperson, honorable panelists, and dear audience. Assalamu alaikum. I am going to present role of external beam radiation therapy in cervical cancer. We all already have heard from Dr. Sadia the incidence of carcinoma cervix, so I don't want to spend time. Then the treatment modalities. surgery, radiotherapy, and chemotherapy. And in all stages of cervical cancer, radiotherapy plays an important role. So today I just want to emphasis give on the role of external beam radiotherapy. External beam radiotherapy has role as definitive radiotherapy, as adjuvant radiotherapy, as palliative radiotherapy. And what is the indications of definitive radiotherapy? What are they? Stage 1A with lymphovascular space invasion. Surgery is the first treatment of choice, but when surgery is contraindicated or patient refuses surgery, then we can give definitive radiotherapy. In stage 1B1, 1B2, and stage 2A1, here surgery is the category 1 choice, but radiation alternatively have the equal result. Then stage 1B3, 2A2, 2B3, and 4A, here definitive radiotherapy is the treatment of choice. Here we use concurrent chemoradiation. And what is the dose of? We give whole pelvis 45 gray, is persistent or bulky parametrial tumor 60 gray, bulky lymph node, then we give 54 to 60 gray, and elective periaortic lymph node if treated is 7 gray in 4 fraction, or cumulative dose will be 80 to 90 gray. Then indications of adjuvant RT depending on the finding of the surgical finding and the disease stage. Usually give in 1A2, 1B, or 2A1. Adjuvant EVRT, that means when we give only radiotherapy, not concurrent chemoradiation, when there is stromal invasion, LBSI, tumor size, by following the SEGLIS criteria. And adjuvant concurrent chemoradiation we give when there is and positive pelvic lymph node. Here dose is for radiation 45 to 50.4 gray in 25 to 28 fractions, and when we give brachytherapy 6 gray in 3 fractions. I have already mentioned LBSI, stromal invasion, and tumor size. Then what is the indications of palliative RT? We usually give palliative RT in case of stage 4B disease. That is when there is brain or bone mets, on there is pain, bleeding. Dose usually we give 20 to 30 gray in 5 to 10 daily fractions given over 1 to 2 weeks, and 8 to 10 gray in 1 fraction. Then accidentally we diagnose carcinoma cervix patient, patient is going through simple hysterectomy due to other cause. Then we give EVRTs, they are recommended along with concurrent chemotherapy and brachytherapy in all stages except 1A1 without LBSI. Then what is the role of EVRT in recurring disease? If there is no history of previous EVRT, then we can go for external beam radiotherapy, tumor-directed radiotherapy, and also with plus minus systemic therapy and brachytherapy plus minus. And if there is history of previous EVRT, if there is central recurrence, EVRT we give in the form of intraoperative radiotherapy, and when non-central recurrence, EVRT will be considered. What are the procedures of RT planning procedures? We give our external beam radiation therapy by 2D conventional radiation therapy, X-ray based, that is X-ray based, that is CT, MRI, PET CT based, and that are 3-dimensional conformal therapy, intensity modulated radiation therapy, volumetric arc therapy. What is 2D conventional planning? What we do usually, target volume is determined by bony landmark is for defining target volume by simulation machine and maintaining proper immobilization and rectal and bladder filling control. Usually we prefer 4-field box technique. And upper border, we all know upper border 4 to 5 junction, lower border 3 centimeter below from lower extent of the disease, lateral border is anterior border, and posterior border, anterior border anterior to pubic symphysis, and posterior border include entire sacrum. These are some figures showing the conventional RT planning in carcinoma cervix. where A is denoting the lateral pin and B is anteroposterior PA. Therapy planning, that is 3D CRT and IMRT planning CT. First, we do the planning CT with proper positioning and immobilization with bladder and rectum filling protocol. Then the CT is referred to TPS, that is treatment planning system. Contouring of tumor, node, and organ at risk are done by the oncologist. Then field arrangement, dose distribution plan, evaluation are done, and finally treatment is implemented. These are the plan 3D CRT and IMRT. Multi-leaf, this is the field planning and with MLC. These are right side IMRT planning and left side, that is 3D CRT planning. It is the dose volume histogram. Now, there are some research, dosimetry comparison, this research. The right one is done in 2018 and left one on 2012. We all are frustrated that we are not getting the opportunity to do the 3D CRT or IMRT very frequently in those who are work in the government institute. But these two meta-analyses showed that toxicity profile is better with IMRT than 3D CRT in terms of disease-free survival and overall survival. The quality of life is better in. And what are the complications of external beam radiotherapy? There are some acute complications and late complications. Acute we found in patients during getting radiotherapy, pruritus, dry and moist desquamation. And late complications, vaginal stage, intestinal obstruction or perforation, femoral neck fracture. Follow-up, we should regular follow-up, that is a very cervical cancer patient, and every follow-up should be done by both the gynecological oncologist and radiation oncologist. According to NCCN guideline, follow-up should be done every 3 to 6 monthly for 2 years, then every 6 to 12 monthly for 3 to 5 years, then annually. What we should do in the follow-up, we should go for history, pelvic examination, investigation, CT image-based, cervical vaginal cytology, and patient education is very important. Prognosis always depends on the 5-year survival, depending on the stage. If we go look at the earliest stage, prognosis is good. And when late stage or advanced stage, prognosis is getting worse. And now I'm telling some important points. That is the radiation stage of cervical cancer, radiation treatment should be completed within 56 days. It is very important. There should be more gap between external beam radiation and brachytherapy. If prolongation of treatment time, survival will decrease less than 1% per day, and local failure will increase 0.6% per day. Treatment option will be unimodal, otherwise complications will be more. Radical surgery or radical radiotherapy. Counseling with fertility expert and treatment of induced menopause if needed. Thank you all.
Thank you, Dr. Raunok, for your nice presentation. And definitely in the last slide, you put some comments regarding the approach of and safety beam radiotherapy and when it should be taken and when it should be completed to offer maximum benefit to our patients. And of course, we know that the complete radiation is completed without brachytherapy in management of cervical cancer cases. So now we have our last speaker, Dr. Aliya. She will be on brachytherapy in management of cervical cancer. Dr. Aliya Shahnaz, she is Associate Professor. College. Dr. Shahnaz, please.
Respected chair, panelists, and all the audience, Assalamu alaikum and very good evening. Thank you, the organizer, for giving me the opportunity screen a bit. So, am I audible? Hello?
Yes.
Hello? Yes, okay.
Yes. Yes.
So brachytherapy is play a vital role in the treatment of cancer cervix. It should be commenced during the last week of external beam radiotherapy or as soon as possible after the completing the external beam radiotherapy. So the role of brachytherapy already, this is stated by my previous speakers. Definitive management is there in case of stage 1A1, and it is equivalent role in as surgery. And adjuvant radiotherapy already stated by Dr. Raunaq Jahan. The high risk groups and also the low risk, that is said list criteria. So I'm not going to go through these stages. Now comes to the common techniques. So intracavitary high dose brachytherapy. So here the dorsal lithotomy position should be done under sedation. Radiopic marker are placed in the anterior and posterior lips of the cervix. Bladder and rectal catheter are placed. Tandem is placed in the midline, and colpostator ring is symmetrically positioned against the cervix. The vagina is packed to displace the bladder and rectum alternatively. Then orthogonal radiograph or CT imaging to assess the applicator placement. So, and then the cylinder, same procedure, but the cylinder, the largest diameter of the cylinder should be used. It must be chosen between 2 to 3.5 centimeter, and CT simulation in the treatment position may be used for volumetric planning. In case of interstitial implant, same procedure of the position, but obturator is placed in the vaginal vault, template introduced over the obturator and flushed the perineum. And the flexi-guide catheters placed into the template as an adequate cover the tumor volume, and template is sutured in the place at 4 corners. Patient should be admitted. Template remains in place for 2 to 3 days. So these are the common techniques. This is a picture of 2D. It is here we can see this. This is the tandem, and this is the ovoid is there in both the fornixes. It is placed, and this is the bladder. And it is a 2D. With the 2D technique, we can calculate the A point, that is with the Manchester A and Manchester B technique in the computer system. After that, this is the 3D technique, and with the 3D technique, actually we used to see the is above this, that is IRCTB, and this is the bladder, and this is the rectum. This is a CT image of the patient, and this is also the one. This is the CT image, and also this is rectum is there behind, and the bladder is there, and this is the point A point, and the A point is especially we the calculation of the dose is measured in the A point. So this is another volume, and this is all the volumes in different planes, and this is the DVH, that is dose volume histogram, with what we can see that doses to the target organ and also the risk part, that is the bladder. This is according to the 2 cc volume, and it is a bladder point, and in the 2 cc volume of the bladder point, this is especially we used to see this point in case of Jack Extro, according to the Jack Extro recommendation, and after that we go for this is also for the rectal point. This is also the 2 cc volume. 2 cc volume here it is 3 gray. It is seen here. And now the dose prescription. In case of 2D, the point A represents a paracervical reference point, has been limitation of point 2 dosing system, including the fact it does not make into account the 3D shape of the tumor, nor the individual tumor to the normal tissue structure correlation. It is typical point A prescription doses is 5 and 6 gray into 5 fraction or 7 gray into 4 fraction for the larger tumors or those demonstrating poor responses. In case of 2D, in HDR, the bladder and rectal points is less than 70% of the point A dose with the HDR, and the ovarian failure usually occur into 5 to 10 gray, and sterilization with 2 to 3 gray, and we limit the uterus less than, and the female guided radiotherapy, we dose escalation to the macroscopic disease and the cervix, which is defined as high risk disease, high risk CTV, HRCTV, and a JKX CTV with D90 of 80 to 85 gray. For the larger disease, it is more than 80. At risk dose limit, that is EQD2, is 2 cc bladder and rectum and sigmoid colon of 90 gray, 70 to 75 gray each for the rectum and the sigmoid colon. And here the high dose rate is 18 to 28 gray in 3 to 4 fractions prescribed to point A or HRCTV. Low or past dose rate is 27 gray prescribed to the point A or HRCTV in a single setting. So recent updates. Recent development in radiotherapy is the use of image-guided interstitial radiation and intracavitary brachytherapy instead of conventional intracavitary vaginal brachytherapy for bulky cervical tumor. This is the picture of our, here we can see that this is HRCTV, the red one, and IRCTV. This is an early case. In the here also we can see the HRCTV red one, and with the blue line we can see this is our IRCTV, and which is very important for to. And this is also one, and it is for the extensive disease, that is 2B to 4A. There is no alternative for surgery beyond the cervix. So this is the one, and this is a huge growth. And so HRCTV and IRCTV also denoted here. EMBRAC2 is the study which has been started in 2018 that combines IMRT and MRI-based IgABT with concurrent chemoradiation. RetroEMBRACE study showed that systemic use of IgABT with combined intracavitary brachytherapy and interstitial applicators, the minimum dose covering 90% high-risk cervical clinical target volume, that is HRCTV, was increased, and patient with large tumor had 10% improved 3 years local control rate.
Dr. Alia, you have 1 minute time.
Image-guided adaptive radiotherapy with repetitive MRI guided as gold standard now in the locally advanced cervical cancer. And these are the complications: acute pruritus and moist discommissions and dry discommission, nausea, colitis, cystitis, vaginitis, uterine perforation, and late, especially the vaginal stenosis. So recommend of our country to treat the cervical cancer patient. IGBT is needs expert oncologists for which training is essential. We have got limited number of brachytherapy centers and all are overburdened with patients, so number of centers must be increased. Not all the centers practice IGBT, which is a modern technique. Time constraint of the physicians. Diagnosis of early case are less, so success of treatment is not that much promising. Much time is needed for availability and reloading, and no dedicated physician for the brachytherapy unit in our country. Thank you very much.
Thank you, Dr. Alia Shahnaz, for your nice presentation. And definitely in your last slide, you have put 8 recommendations regarding brachytherapy in management of cervical cancer, particularly the scarcity of our different issues, the centers, the machines, and the dedicated personnel. Definitely, these recommendations will send to World Health Organization from our session. The presentation from our 4 learned speakers. We will listen from our expert panelists, but in between, we have a few questions from our participants, and this indicates that they're eagerly and very interestingly they were. I am taking this question before going to panelists. The first question is from Dr. Saeed Hussain. He is Associate Professor of Radiation Oncologist, NICRH. About the whole population were indicated for HPV vaccination. And another question from him, what should be the national strategy for a successful eradication program? Going to the speaker, but to any speaker can answer this question, but I want to remind that the target of World Health Organization is 90% women or babies below 15-year-old should be vaccinated by 2030. So this is a huge task. So this is very relevant question which asked by Dr. Said Hussain. So anyone, it may be from Dr. Sadia Sharmin or any speaker can answer this question, how much time it will require and what should be our national strategy.
Sir, I want to add something.
Yes.
That is our the WHO or World Health Organization's target is by 2030, we should cover 90% our target population to be vaccinated. You already told, and our national strategies are to be taken to vaccinate our 10 years old girls, that is the grade 5 or primary school girls. It is a school based program to reach the target population to vaccinate, and the women or the girls who are not at the school should be targeted or should be reached by community based program. This is the national guidelines or that has to be discussed or has to be taken, but yet not success. I think it is maybe the COVID situation or like pandemic situation, we are some lag behind from this strategy, and from when the situation is be overcome, I think this will be taken, that is a vaccination program should be spread in the community based level. And now there is a pilot programs are ongoing in some upojila, that in Gazipur there are some pilot projects of this vaccination. Now it is going on, and from this result we can assume what time or how long it should be taken to vaccinate.
Thank you, Dr. Sadia, for your good answer. And definitely, this is the way to proceed to achieve the target. But this is the high time to raise question to our policymakers, particularly who are dealing with eradication of or elimination of cervical cancer from the globe and in our policymakers. Another question was what should be the national strategy? This strategy should include, in my opinion, that is public-private partnership. There should have some approach to achieve very quickly because time is short. We have to achieve by 2030. Another question from Altaf Hussain Riyadh. Can brachytherapy be used during the midpoint of EBRT? So it is directly to Dr. Alia Shahnaz. Dr. Alia, can you? Yes, please.
Okay. Yes, brachytherapy can be started in the early stages also, but there are some schedules. There are some also some recommendations in different parts of the country, so it can be done in those stages.
That is
that part of the with the EBRT.
That is midpoint of the EBRT.
Yes.
Yes. Okay. So another question again from Dr. Altaf Hussain Riyadh. How we select the appropriate size cylinder for individual patient? Again, it is to perhaps
okay. Yes.
Dr.
Thank you.
Shahnaz.
Thank you, Dr. Riyadh. Actually, we just do the Hpv, that is per vaginal examination, and with the per vaginal examination, we introduce the fingers into the fornices, and then with our experience, we actually measure the diameters of the ovoids.
Perhaps I don't know how. So we are have any more question. Any question?
Sir, I have
Please,
I want to know about the
Yeah.
mesometrial resection.
Okay.
About
Yes,
the
please.
mesometrial resection.
Mesometrial resection. Could we take the sacral, presacral lymph nodes also with this resection, like mesometrial resection that is
Yes.
already going on?
Actually, presacral lymph nodes is a part of the pelvic lymph nodes. And in cervical cancer, our aim is to remove the all the lymph nodes, irrespective of their size and enlargement. So if the presacral lymph nodes, we try to remove that presacral lymph nodes, parametrial lymph nodes, and also the lymph nodes in the pelvic side wall.
Thank you, madam, for your answer. So now we will go to our expert panelist. We have a very learned and very vast experienced panel in our session. First, I would like to request Professor Begum Rokia Anwar. She is head gynecology of National Institute of Cancer Research and Hospital. Madam, would you please the motto or the target of World Health Organization, and of course our four presenter. You can choose one or two presenter to put your comment. Ji, madam, please.
Am I audible?
Yes, you are.
And good afternoon and assalamu alaikum to you all. At first, I like to give thank you, Professor M.A. Haisar and our senior teacher plus he has first presentation regarding cervical cancer screening. Actually, I am very much interested to hear from our Associate Professor Dr. Said, at least radiation, to know how long it will take to eliminate cervical cancer. We are under national screening program by VIA. Just think it, when we have no travel, no air travel, at that time, we travel by rickshaw or bus, but nowadays we have plane. So we curtailed our time because our time is valuable. So the life of women also valuable. I think this is the time to decide what will be the method of screening test. 90, middle one, 70. We should have treat all by high precision test. That high precision test is human papilloma virus DNA test. We can triage our population. We could reduce our colposcopical burden. We are living in a country where resource is very low, but we have skilled doctors, physicians, and health workers, and good organogram. So I think policymakers together to think that we need different modalities of screening, not only by VIA. The specificity and sensitivity of VIA is low, less than 60%, but negative predictive value of human papilloma virus test is more than 99.9%. So we could use that test. And another advantage of the test is we could do a self-sampling test. We would send our kit to the women in their house. They take their sample and send it inter-center, and it contains transport media, so no chance of default result. So high precision test should be used, it should be included. On the other hand, we are frustrated that national screening program going on for last 15 years, only 20% is coverage. But it is my thinking the coverage is not 20%, it may be high because we are very poor to save our data electronic. In our center, last 5 years, I have tried to include MIS in our data, but unfortunately, I have seen that during COVID pandemic, our data has not entry into data MIS, data tracking center. So we should have to put our data and not only single modalities. We have those VIA, HPV DNA or cytology. Whatever it is feasible for that eligible candidate. In our private practice, is it possible? In my position, I like to do human papillomavirus DNA test. In this month, I already did 100 tests, human papillomavirus DNA test. And I urge to every member of this society, not only is it a health problem, it is a public health problem. So we have to include community workers, we have to include community medicine department, all medical colleges, and we have to salute all them, those who are doing cytological test and should be included into the electronic data system. Patients are not very easy to come to hospital for their screening test for 3 to 4 times. So once a screening test, a screening test reduces 70% of cervical cancer once in a life. On the other hand, another thing is very important, vaccination. I think it would not be any problem because this girl will attain at the age of 20 after 10 years in the year 2030. The risk of cervical cancer is very low in this age group. But I appreciate our government policy to bring the vaccine. Of course, pick up those who are between 25 to 65 years old. Don't keep them out of screening. Whatever, wherever we get the patient, we should screen. Next presenter, Dr. Janatul Firdaus Junaki. She has elaborated surgical procedures very nicely. So here I like to just add that our aim of mainly is by single modalities of treatment. We have to be careful to give the patient only one modalities. The oncosurgeons are doing surgery and the patients are referred to different institute to combat their morbidity. Some are unfamiliar with that kind of morbidity. So my request is we should do surgery only in early stage case. That means up to stage 1B1, where single modalities of treatment will give maximum benefit and morbidity is very low. So in case of stage 1A1, just we can go for simple hysterectomy or lab assisted vaginal hysterectomy that will give cure patient 100% and patient can go work within a very short time. So we have to be careful to avoid morbidities of surgery. So this is my opinion regarding
Okay.
to. So thank you very much.
Okay.
Giving me scope.
Thank you, madam. Thank you, madam, for the analytical comments regarding two speakers. And one very burning issue is that whether VIA is minimum cost, but because of specificity or sensitivity, if we consider this issue, whether this is cost effective or not, cost minimization is not the only issue that should be cost effective for national program. Thank you very much for your comment. Now I would like to request Professor Sarwar Alam. He is chair oncology department of Bangabandhu Medical University. Please, sir, please put comment one or two about one or two speaker, and if any other point towards the strategy of World Health Organization. Professor Sarwar Alam.
Thank you, sir, for giving me the opportunity to say something. Honorable President, Professor Mullah Obaidul Bakir sir, for this session. Today's topic is cervical cancer free feature, first ever global commitment to eliminate cancer, a 100 years target of WHO. Honorable speakers, our experts, and our mentor, Professor Mahai Saib. Assalamu alaikum. I am very much impressed and feel happy to hear the today's topic title. Really, it is ever first to my knowledge. Thank you, Farooq sir, again to arrange such type of topic, and we expect it will discussed later on time to time because it's a vast area. Cervical cancer free community, really it is a challenge. I think so, because our poverty, our economical strain, patients' perception about the disease, and the knowledge and attitude. So it is really a challenge. But I think the mission is not impossible, because most causative factors on cervical cancer are identified. And interestingly, they are so modifiable by our lifestyle awareness and taking other programs. And especially because cervical cancer, and we are identified in near future about other vaccine that may cover most of the people, as mentioned our expert Anwar Madam. Our today's presentation, really we have heard from our four speakers, very knowledgeable and nice presentation. As Sadia Sharmin, our associate professor of clinical oncology, mentioned about epidemiology, and Professor Jannatul Firdaus Madam, she elaborated about the role of surgery, and also our Dr. Ronak Jahan, the rheumatologist, she expressed about external radiotherapy in cervical cancer, and last but not the least, our very Shahanaz, as a professor of radiotherapy, she expressed about the very important role, newer aspect of brachytherapy. So thanks to four speakers about their presentation, and last of all, I am privileged to be here as an expert. Thank you, Farooq sir. Thank you, our president sir, for giving me the opportunity. Thank you all. Thank you very much. Assalamu alaikum.
Thank you, Professor Sarwar Alam, for your nice comment regarding all the speakers and, of course, the target of WHO. I can recall that the vaccine was invented in the HPV vaccine 1976, and the German scientist, he was awarded for that. But whether this is applicable as the preventive issue in cervical cancer, it was launched in 2006. So it took 30 years. So it's a very difficult job to achieve the goal of world. We have the apex body of cancer management, prevention, and all other things in our country. The National Institute of Cancer Research and Hospital. So now our speaker, Professor, he is a leader of this area. I would like to request, keeping in mind that this is not a health issue only, this is a public health issue. Professor Kazi Mustaq Hussain.
Thank you, sir. Professor Haiser and respected teachers and distinguished guests and learned audience. It's very important, and this time this is, I say that it's very important and a war against cervix that the world protect life of our women. So we know that this cervix is a preventable disease caused by a virus that can be prevented, and we can protect our women. What we need to do a plan to eliminate. How can we go? How can we work to prevent this, or the program to make a success? WHO, UICC already calculated that if we work with this type of vaccination and screening program, it will take 100 years, 2120, to make it a success, to make the world free of, say, cervix. And if intensive screening and vaccination program taken or provided, only then it will take 50 years from now, 2070, to make the world, say, cervix free of cancer cervix. So it's a big challenge for the humanity, for the world leaders, for the countries to continue a war. I'll say it is a war. We can say it is the third or fourth world war. So we need, what I say today in morning also, we need awareness. We need to make a plan, to involve our media. We should include it in our education policies, education books and school level, because we will vaccinate the girls at the school or college girls. And also we have to keep in mind, we have to vaccinate the boys also. And already England, Australia has started vaccination among boys. So this is important. It should be kept in our mind and policymakers. And awareness building is one of the important work. Then we should go for the early detection, and we can detect earlier, we can treat it completely. So for early detection, we need screening, and after screening, we will get the diseased women at the very early stage, at the asymptomatic stage, and then we can give treatment. But here we have to think the treatment facilities. We do not have adequate treatment facilities in our country. We only have 30 to 31 centers in our country. Not all the centers have radiotherapy. In our country. So this is a very difficult work for the patients we have at present time, or during these 50 or 100 years. We have to, not only we have to vaccinate or screen, we have to treat our patients during this period of time. So we must increase our treatment centers. According to the population based, we have to have more than 160 centers, at least 59 point something, we can say to 60%. According to this, we must have 80 centers with all the teletherapy and brachytherapy facilities. So we need at least 80 multiplied by 3 machines. We need 250 machines, but we have only. How can we go for the elimination? So my next comment is prevention or vaccination for both the sexes. Boys should be treated. And I would conclude by giving thanks to our 3-4 presenters. They told us excellently, brilliant presentation was that. We learned our viewers through Facebook or other transmission. We have many guests who are looking at this program. I think that they will have much get information, and there will be interest in them how to what is going, because the WHO has declared the vaccination program in 17th November this year, 2020. So Bangladesh will bring the vaccines this year, and we will start vaccination. WHO Assistant Director General, Dr. Princess, I want to cite from her, and after this I will conclude. With this, I will conclude my comment that she said that critical developments include the availability of prophylactic vaccines, low-cost approaches to the screening, and she also said the fight against cervical cancer is also a fight for women's right. The preventable disease reflects the injustice that uniquely affect women's health around the world. Together, we can make history to ensure a cervical cancer-free future. Thank you, organizers, for inviting me and for this presentation. Thank you very much.
Thank you, Professor Mushtaq. You told that this is war against elimination of cervical cancer from the globe, and simultaneously you put some comments with what are the weapons to do war or to face the problem and to overcome the problem. I have one minor correction from my side. I was telling that the vaccine was invented in 1976. Actually, the association between human papillomavirus and cervical cancer, that was introduced and awarded with Nobel Prize. But the target of World Health Organization is to award 62 million cervical cancer patients in next 100 years. So it's a huge task. Saying this, I would like to request Professor Molla Obaidullah Baki, president of this scientific seminar, to deliberate his speech as a president of this session. Prior to that, my gratitude to Rehelp TV and Opsonin Pharma to support us in this occasion, and definitely the viewers, the question who raises question, and definitely our all participants, presenters, panelists, my gratitude, my heartfelt thank to them. And I would like to request Professor Molla Obaidullah Baki, President, Bangladesh Cancer Society, to conclude the session by saying few words from his side. Thank you very much. Sir, unmute, sir, please.
Thank
Yes,
you
sir.
all learned speakers, panelists, and our mentor, Professor Heiser, along with the Professor Gulamuddin Farooq. Actually, thank you very much on behalf of Bangladesh Cancer Society. We have arranged this seminar or Zoom meeting, webinar meeting, along with the help of BSRO. So we thanks also Professor Kazi Mustaq Hussain for his cooperation. Actually, we are about such a cancer, the one which can be, the one can actually eliminate. It is time to do it. Following a call to action in May 2018 from the WHO Director General, Dr. Tedros, 194 countries collectively resolved to end these endless sufferings from a cancer that is both preventable and curable. Actually, to eliminate such a cancer, which is the second position, commonest cancer in developing countries and fourth in the world. But actually, the way the human being or the it is difficult to manage them for education or prevent or screening like this. Actually, to eliminate the cervical cancer, we have to look first. It means screening followed by treatment of precancerous lesions of cervix, then treatment or like this, proper treatment. But for prevention, what we have discussed, that vaccination is the prime. So, but due to VIA, we are using VIA elaborately in the whole country. It is, I think, it is still, we should be elaborately used more along with the colposcopy like this to detect the cancer. For maintaining the education level of Bangladesh, our government is trying to do free of cost up to class 10 for the women, for the girls, free education. So we hope we can reach the goal of what is declared by WHO in 2018, the elimination of the cervical cancer. So Bangladesh, we are the such a position that we can do if we try. Our government is headed by Sheikh Hasina. I think we can take proper measures to do this, everything to share the declaration of WHO. Such as, you see, tomorrow we are going to join a meeting. And now the country in Bangladesh বলি জরায়ুমুখ ও স্তন ক্যান্সার সপ্তাহ কিন্তু বাংলাদেশে চলছে সরকারের পক্ষ থেকে, স্বাস্থ্য অধিদপ্তরের মাধ্যমে, এবং আগামীকালই কিন্তু আমরা ডিজি অফিসে একটা মিটিং এ সম্মিলিত হচ্ছি এরপর আলোচনা করার জন্য। মানে গভর্নমেন্ট খুব সচেতন, তাই না? এটা একটা গুড স্টেপ আমি মনে করি। এবং আমাদের অনেকেই প্রফেসর সারোয়ার বললো, প্রফেসর মুস্তাক বললো যে আসলে ইলিমেশ এই কথা কিন্তু পৃথিবীতে নতুন আসছে, তাই না? কিন্তু আমার ধারণা হয় 100 বছর আগে। কিছুদিন আগেও বাংলাদেশে কিন্তু জরায়ু ক্যান্সার 1 নম্বর ছিল। 2018 সালে গ্লুকোকানে আসলো সেকেন্ড ইন পজিশন। সো উই আর লাকি দ্যাট আসলে এই অল্প দিনে আমরা কিন্তু ক্যান্সার আমার দেশে আমরা কিন্তু সেকেন্ড পজিশন আনতে পেরেছি। তার একটু কাজ করলে মানে আমরা, অথচ উন্নত বিশ্বে কিন্তু 9-10, তাই না? তা ইরাডিকেট বা ইলিমিনেশন করা আমার মনে হয় এটা সময়ের ব্যাপার। আমার মনে হয় না 100 বছর লাগবে, তবুও, তাই না? থেকে সব এটা প্রবলেম, সোশ্যাল প্রবলেম আমাদের ওইভাবে জনগণের সাথে নিয়ে আমরা এটাকে বাস্তবায়ন করবো। সমস্ত পদক্ষেপ নেব, কিভাবে নারীদের শিক্ষা দেওয়া যাবে, কিভাবে ভ্যাকসিনের প্রতি আসক্ত করা যাবে, কিভাবে আর্লি ডায়াগনোস করবে, কিভাবে আর্লি ট্রিটমেন্ট করবে। সংস্কার আছে যেটা কোফ্যাক্টর, যে আর্লি ম্যারেজ, পার্টনার এগুলো এড়ানো এবং হাইজিন মেনটেন করতে, বিশেষ করে, তাই না? এই স্মোকিং আজকাল বলা একটা বিরাট ফ্যাক্টর। এগুলো যদি আমরা রিস্ক ফ্যাক্টর গুলো অ্যাভয়েড করতে পারি, তাহলে আমরা কিন্তু সার্ভাইকাল ক্যান্সার, এটা আমরা সেই গোলে পৌঁছতে পারবো। সবাইকে আবারও ধন্যবাদ। বাংলাদেশ ক্যান্সার সোসাইটির পক্ষ থেকে ছোট ডিক্লারেশন দিয়ে যাচ্ছি। আমরা এই জরায়ু ক্যান্সারের পর আগামী 31 বিকেল 6টায় কিন্তু আমরা প্রফেসর উবাইদুল্লাহ ফেরদৌসী ফাউন্ডেশন, যেটা আপনার মনে করেন আমার নামেই, সেই আমরা একটা জুম মিটিং অ্যারেঞ্জ করছি, যেখানে দেশি বিদেশি আমাদের সমস্ত এলিট পার্সন থাকবে। আপনার সবাই আমন্ত্রিত সেখানে। ধন্যবাদ সবাইকে আবারও ক্যান্সার সোসাইটির পক্ষ থেকে ধন্যবাদ।
Thank you for your presidential speech. Now I will wrap up the session. Again, my gratitude and heartfelt thank from my core of heart for our presenters, speakers, Professor M.A. and of course the expert panel and the participants who and definitely we will take the opportunity how we can assist our national program to eradicate a single cancer